I'm Dr. Mark Sue, and welcome to the Functional Medicine Reality Podcast. Join me and our community weekly as we bring you unfiltered health from inflammation to longevity. Real stories, real people, real solutions. Experience real-life health changes from both patients and practitioners, and learn how to turn cutting-edge information into real results in your own life so you can feel better, live longer, live healthier, and be confident and clear in your healthcare choices. Let's get real and get results. Hey folks, welcome again to the Functional Medicine Reality Podcast. I'm Dr. Mark Sue. I'm here today with my friend Amy. Amy and I have known each other actually and our spouses as well, for probably close to 20 years, I think.
Yeah.
Did we know each other before we had our kids?
No, I think they were just born, maybe 3 months.
That's when we first met, after they were born?
Yeah.
Okay. Yeah, so they're about 20. So yeah, it's a little over 20 years then.
Yeah. They're
Yeah.
almost 21. Crazy.
Yeah, so our kids are both on the western half of the U.S. in school, different schools. So today, I'm going to let you introduce yourself in a second here, Amy, but just setting the stage for us here.
Uh-huh.
This is one in our series of chats and interviews and insights with colleague professionals. Our intent, as always, is to bring not just education, but insight and deeper and more unusual angles of insight into what we experience as patients and at times as providers, so that people have a better understanding and context of their healthcare experiences. And our goal is to help people make better decisions so that people are spending less time, money, and effort in getting better faster so they can live their best lives more efficiently, more quickly. So that being said, let me just briefly say, Amy, so you and I don't know, about a month ago-ish maybe, we run into each other at Staples. We hadn't seen each other in, it could be 10 years.
Yeah.
Possible?
At least. Yeah. Yeah.
But first of all, just on a totally relational and human level, I haven't said it yet, but I just really appreciated who you are as a human, that we, hadn't seen each other in freaking 10 years. And it felt to me like we just reconnected like it was yesterday. It was
Yeah.
kind of fun. It was
Yeah.
really,
I love that. Yeah. That's how you
really
know
fun.
it's a good friend, right?
Yeah, and I think for me, it's just a testament to the kind of person you are, that, just down to earth, grounded, and, just a good human, right?
Thank you.
And I was glad to hear that your parents are well, and the rest of your family. So with all that being said, I'll shut up here. Let me let you introduce yourself. We knew each other initially. I think, actually, last thing, did I know your mom first in the hospital?
No.
Right?
She was working as a labor and delivery nurse.
Because I was
You
delivering
might
babies back then, 22, 24 years ago.
She might have been involved in one of your deliveries.
I know we were involved in at least one delivery. So it's
Yeah.
possible I knew her before you and your husband and my wife and I met.
Yeah.
So,
I
well,
think we met through originally, maybe through Dr. Papanicolaou, and I kind of arranged my husband to be your physician, and then you recognized that you both went to school in the Midwest, and there was that IU Purdue connection there.
yeah. Thanks for bringing that around. I think, yeah, you're right. So I think in either case, it was more than just us meeting through kids. It wasn't through a kid group thing,
No.
newborn babies
Mm-mm.
thing.
No.
So yeah, let me let you introduce yourself. But so your mom and yourself have been a nurse for a lot of years, and you've had now, as you were updating me just about a month ago or less, you've had a change in your professional career, and I was just really stimulated and intrigued by what you were sharing about what you do for your work. And as I explained to you, I wanted to invite you to have this chat because a lot of what you do in the hospital now, in a total different capacity than what you did for close to 20 years at the bedside, has meaningful impact from my experience with patient care, from what I hear from patients with a experience in the hospital when they're in the hospital. And then certainly for me, the experience that I'm encountering when having a post-hospital discharge follow-up visit with them.
Right.
So yeah, let me let you introduce yourself.
Okay, sure. So my name is Amy, and I'm originally from New England, born and raised here, and have spent most of my career here. I went to the University of Massachusetts in Amherst, Mass, and got my bachelor's of science in nursing back in 1997. I had to do the math today. I'm officially a nurse for 28 years. And when I graduated nursing school, I knew I loved nursing. I knew I wanted to be in healthcare, but I didn't know what type of nurse I wanted to do. So I kind of worked my way up slowly. I started off at a pediatrician's office, then I went
Mm.
to a cardiac floor at a small community hospital. I went and did spinal cord injury at a rehab and learned how to take care of patients on ventilators and all the spinal cord issues that come along with that.
I
And
don't
then
think I knew that.
yeah. And then I finally felt like I had a good base knowledge of nursing and I was ready to challenge myself even more. So I went to one of the level one trauma centers in Boston, a teaching hospital, and got taken into their ICU consortium and was trained to be an ICU nurse and worked on their thoracic ICU that was just opening, which was amazing experience. And then I took a pause and decided to go out and be a travel nurse. And I went out to California for some time and worked at Stanford Medical Center.
I definitely did not know that. Holy
Yeah,
crap.
that was before I settled down and got married, but it was great. It was great to be in a different part of the country. It was great to be at another level 1 trauma center, teaching facility, and then I knew I wanted to come back to New England and live, and I knew I wanted to be in Boston when I came back, so
Mm.
I was fortunate to get a position in a medical ICU at another level 1 trauma center teaching hospital in the city, and I stayed there for over 20 years, 2 years in the medical ICU and then about 20 years in their post-op anesthesia care unit, which is considered a critical care unit. We took care of patients that had craniectomies, bypass surgeries, transplants, traumas, everything right out of the operating room.
Serious events.
Yeah. Yeah. So I loved it because every day was different. You know, you very rarely had the same patient the next day when you came in because the goal was to recover them, get them stable, and get them to the floor. Or if not, find them a place in an ICU where they could have more consistent care because it was a quick turnaround in the recovery room. But we had some really sick patients, but it was amazing. I loved it. So I stayed in that position the longest because it just met all my needs, right? I got that ICU, a critical care on a daily basis, but I got to see patients do well and do better and move along. And I guess the funny thing is that leads into my new role is one of the things that I missed when I worked in the recovery room is that I never had time to read the patient's chart. It was stabilize them, get them what they need to get them to their room or where they had to be. And
Uh,
I missed that story part about the patient, like what brought you
I'm sorry,
here?
do you mean when you were working there, you didn't have that story, or you're saying you miss not
I
having that
missed
story
out.
now?
I miss not having the ability to and the time to read the patient's chart and find out who this patient was, why were they here, what brought them here. It was so fast, the turnover that you didn't have time to delve into all of their past medical history or,
Mm.
psychosocial aspects of who this person was at the bedside. And after COVID, we turned into a COVID ICU. And after that, I kind of was just reevaluating where I wanted my career to go and what next steps I wanted to do. And I found it's fairly new. It's in its infancy stage, they say, because it's really only been around for about 20 years, but it's clinical documentation integrity. And we are a group of nurses that are hired by the hospitals. And we play a role, we're the bridge between the providers, the physicians documenting, and when it goes to the coder that has to pick up the diagnoses and what's being captured before it goes to billing. So we're kind of like the clinical in between the provider and the coder because coders don't have clinical background experience and we do. So I love what I do. It's exciting and I finally get to read the patient's story. I go all the way back sometimes to admissions before they were even came to this current admission that I'm reviewing and I get to read, past medical history, psychosocial, their concerns in the moment. Yeah, I love it. Among other great things that we do, but I can fill you in on that if, you want to dive deeper into what it is.
Yeah, so you went from, bedside, direct patient care, hands-on, high acuity even. It's
Mhm.
actually much more high acuity than I either recall or knew, okay?
Yeah.
Because I don't recall that it was, full-time, that level of, yeah, of, illness or acuity or surgical, etcetera. And now you're you're basically effective essentially non-patient facing at all.
Right.
Okay, so you went from then it's like all hands on and didn't have much background because it was all hands on deck, and now it's don't really actually see the patient, but you have a lot of information in front of you about the patient's story.
Yeah.
What a flip!
It is a flip. It is a flip, and people asked me, people were concerned when I was going to make this change, was I gonna miss it, And,
Yeah.
because you don't go into nursing for the money, you know what I mean? You go in and you stay in because it's a passion and it fulfills you in so many ways. And so I think the timing was just right. I had done it for so many years. I'd given 110%, and I feel like I had made my impact. And so I I wasn't worried so much that I was gonna miss it. Um, I knew I would, but I was excited for the challenge because what I am doing now required so much relearning and almost learning a whole
Mhm.
new career for me. And so I knew it was going to fulfill me in a different way. It was more
Yeah.
mentally and academically. And I think, when you do something for so long, you kind of get into not a rut, but routine.
Yeah.
And my day was becoming routine and I wasn't feeling challenged anymore.
Hmm. Yeah, that was one thing, I certainly was really heartwarmed to hear. I asked you some questions along those same lines when we reconnected recently about, what your experiences, comparison, contrast, and you seemed, very content and fulfilled and challenged, et cetera. So that's a great segue. One of the things I wanted to kind of just lead off with here, first of all, as we get into this, I think where we're going, what we decided as a sort of all encompassing take home point here, right? This is, yeah, we're going to kind of get into a little bit of your experiences and my experiences intersecting on the sort of front and back end of patient care in the hospital. But I think a lot of it is under the umbrella of information, the rapidity and speed of information acceleration and overload and requirements and demands that our patients are assimilating, bringing to the table, including in hospital settings, which you can fill me in more on. I don't know that I hear about that much. But then all the impact that has on the providers in the hospital, and then all the back end stuff that you're doing that the patients never see, some providers may have some familiarity with. I don't have any familiarity with because I'm not working in the hospital anymore. And then how that translates into patient experiences feeling kind of, in my opinion, disempowered or confused, fragmented upon discharge, and
Mhm.
no judge, just
Yeah.
that's just a common experience. And how do we manage all that stuff, right? Or just be aware so that we can start to have more patience with each other, whether provider patients or provider with provider or provider with administrative staff as you're kind of in that role for you now. So all that being said, locking in here, what do you have any more meaningful reflections about patients' hospital experiences from the patient side since you've undergone this transition? Because you've worked in this capacity now, what, but I think 3 years, you said?
Yeah. 3 years, yeah.
Okay. So, yeah, any kind of big reflections on how things have evolved over time with the patient's experiences being in a hospital?
I think, like I said, with access to AI and the online medical record now being at patients' fingertips, they are feeling more empowered and wanting to be more involved in their decisions and their health. I think there's a big shift I've noticed in people wanting to be healthy and being proactive, whether it's going on medications with a GLP-1 to lose weight, to, help them overall have a better quality of life and decrease their risk of other comorbid conditions. I think patients are just, finally able to get an inside picture of things that they probably never used to be able to get now. And
Hmm.
I think it's really eye-opening for them. I had a recent experience with a family member and I was talking about what I did and they said, "Yeah, I just had my physical and they gave me this paperwork and on it it says I had chronic kidney disease stage 3." She's like, "I never heard that before." And I was like, "Oh boy, here we go. This is exactly what Mark and I are going to be talking about." And so
And that one is a
it's
super
really funny
common
because
example, by the way. That's a super common example.
yeah. Yeah, and it kind of for me, I was like, "Whoa, CKD3, like that's, that's not stage 1 or stage 2." But in my head, I'm like, "Is it really stage 3 or did you
Mm.
just have a lab level that was drawn on that particular day that put you in that reference range? Maybe you were a little dehydrated. Maybe you took your hydrochlorothiazide that day." So It's funny and not funny, but I am seeing both sides of it because what I'm trying to do when I'm reading the medical record, from a clinical documentation standpoint, is I'm trying to make sure that when the patient leaves the hospital, that everything that's documented in the medical record is accurate
Uh-huh.
and meets reportable criteria so that it can be billed for, but it has to meet criteria and it has to be accurate. And so that's my role. And so I'm seeing the job that I'm doing reflecting into the outpatient, or like you said, when you have patients that come and see you, and how that affects them, right? Is it something that they should be aware of? And how much should we be divulging because we don't want to create anxiety? I know when that family member told me they had CKD3, that family member is also medically inclined and has a background and know what that means, right? So
Hmm.
now you're at home and you're reading that, and you can't just pick up the phone and call your doctor and be like, can you explain this? It's, 7 o'clock at night and I just noticed it. So yeah, I'm seeing it kind of come full circle, how online medical record, AI, access to healthcare is really affecting patients positively and negatively.
Yeah. Yeah, and I think I'll extend off of that example and then bridge us into, a meaningful next thought question I have for you is, so I don't want to go down this rabbit hole too much, but you say, hey, maybe that chronic kidney disease stage 3 was listed sort of in direct response to a lab that might be an outlier lab for that person,
Right.
right? Without going into detail about CKD as a condition, I mean, there's a lot of people just by numbers who have CKD too. And you've already
Mhm.
alluded to, like, okay, that may not be as big of a deal, even though we give a diagnostic name to it, which is a little bit of a paradox, right?
Yeah.
But hey, if your number was low enough just for that one time that you fall into category 3, or likely what we call 3A,
Mhm.
then what's the point of calling it that if that's not the baseline for that person, right? And here I will purposely sort of be a little provocative to say, it's not unlikely that in some cases it could, if somebody chose that manually, it's not unjustified because the value by definition is CKD3 or 3A,
Mhm.
but that can have some reimbursement potential effect, right?
Correct.
That can have greater reimbursement. And again, as an outpatient, in the outpatient setting, I know from meetings that we've had, because our office works through insurance and all that stuff, that it's a whole budgeting system, right? These insurance
Right.
plans, I don't know if, how much this is the case with inpatient or if you're
Mhm.
even aware of this stuff, but for us, we know that insurance plans, especially, Medicare leading the way, and I believe all plans are the same, when we list certain codes, and I know this is applicable to you guys in the hospital too, because you've shared that,
Yep.
when we list certain codes, then it not only has a sort of monetary financial value to it per se, but in the outpatient setting, I know it also sort of sets a budget for the next year,
Correct.
right? And so I don't know about the hospital, but for us, like we're always being told, and we try to be mindful, but we're in our office, we're not set up to sort of like drill down on this stuff and really overly focus on it. Maybe we should, I don't know, but it's a balance. I try to do our part and be team players,
Yeah.
but to the system at large that we're part of. But we don't. It's not like we're nailing it on each one. But if we set those more specific diagnostic codes, as you and I talked about in Staples, then it's not even just for the here and now with the reimbursement for that visit or that hospitalization, but it sets a budget for the future so that insurance plan says, okay, next year we'll set this kind of funding aside because based on last year, this is what we're holding aside and kind of giving as a reservoir, whereby you have to then, you might be able to meet those criteria, you might not, but it gives you more opportunity, let's say. So the
Mhm.
question now is, if there's somebody listening, if there's somebody in the room with us here, the virtual room with us,
Yep.
and they're kind of jaded or skeptical, because I don't know about you, but I mean, for me, it's just a dime a dozen of people who are just skeptical about the healthcare system across the board these days, right? Since the
Mhm.
pandemic, just other social political evolutions. If
Yeah.
there's someone out here listening and going like, yeah, the whole system's just all about money. It's all about like, the system's kind of broken. It's all about trying to just generate more, more of the green stuff.
Mm.
What is your insight on that? And, with your background, with your position where that is your role is, yes, it's integrity of the documentation. And some of that naturally inherently translates into reimbursement potential for hospitals. But yeah, we talked about this briefly, but
Yeah,
how do you feel about that? Are you okay with it? Like, what do you say to the skeptic?
I do. I actually feel really good about it because when I was a nurse, I thought that every IV tubing we used or every bag of fluid was a charge, and that's not the case. Patients get, um
I still think that to this day. That's news
I
to me.
know. We don't scan everything that we use or, maybe the medications we do, but everything we take out, we don't scan. The number of sheets that we use or, pads that we use and washcloths, all of that, like we don't scan any of that. The number of urinals we go through, that when a patient comes in, especially with Medicare and Medicaid, the reason for their admission after the workup, the diagnosis gets put into a group. And I'm not going to get too complicated here, but if you get put into a group, say you come in with pneumonia, you're put into this group of pneumonia. But if you have, like I think I mentioned to you, a history of CHF or chronic kidney disease, right? Maybe you're on dialysis. Well, that particular patient has a greater risk of mortality
Mhm.
and a higher severity of illness because someone that doesn't have any other comorbidities that walks in with pneumonia and say they just need some oxygen, a chest X-ray, and some IV antibiotics. They might be out in 2 or 3 days, maybe 2 days at most. But if you have congestive heart failure and we gave you fluids, we had to, and then maybe now we have to give you Lasix because now you have some component of your heart failure kind of merging up. Well, now you're not just coming in with pneumonia. Because of all those other comorbidities, the care that's required to take care of you is greater. And
Yeah.
so, as healthcare providers, we want to capture all of that because it's resources, right? The provider isn't just taking care of pneumonia, they're looking at all the other indicators that they need to take care of that sicker patient. It requires more nurses. They may need dialysis because they normally get it at home,
Mhm.
but now we have to do it in the hospital. We need to capture that. So it's not about, to me, I don't feel it's about money. I feel it's about making sure that we are capturing all the resources that are being utilized in the hospital to quantify all that care that was given.
Mhm.
Because hospitals is but partly about money. You have to get reimbursed. You have to pay your providers, your nurses, and all of the equipment that you're using. Um, and like you said, at the end of the year, hospitals and physicians are given and those scores depend on the reimbursement that the hospital will get. Poor
But
scores,
I
the
think
insurance company might not pay a certain amount for that admission, or insurance companies might not want to extend their contract with that hospital because of poor scores.
wow.
We need to show that we're taking care of really sick patients, and the resources that go into it. It
So
helps
what are those
support
scores based on, real briefly there? I mean, when you say scores, are we talking
everything.
about
Like,
the scores based on the diagnostic codes?
no, the scores I talk about are more like quality and
Yeah, yeah.
preventable
Yeah.
hospital acquired conditions. Brief, like just for an example, if someone comes in with pneumonia again, right? And they're otherwise healthy, right? But they unfortunately pass away. Well, if they didn't have any other comorbid conditions listed in their documentation, why did that patient pass away?
Yeah.
You shouldn't just pass away from pneumonia. If we're not capturing all those other comorbid conditions that increases that patient's severity of illness and risk of mortality, well, if they come in and we use scores 1 to 4, right? So 4 and 4 is the worst. If they come in and their risk of mortality and severity of illness is a 4 and a 4 and they end up passing away, well, it kind of shows that there wasn't there was a lot working against the providers in order to save that patient,
Yeah,
you
there's
know?
less of a likely sort of like ding or penalty.
Right, exactly. Right. But
It's more
you get
understand I mean,
dinged or
not to devalue.
penalized if that patient wasn't very sick and they,
Yeah.
leave sicker than they came in. Right.
Yeah.
So scores like that. So I don't necessarily feel like, it's a money thing and we're trying to go after the money. We're trying to quantify the resources that are being used.
Yeah. Yeah, and in the end, I think we talked about, I'll just throw in kind of on that side of the argument
Mhm.
that it's a little, I think it's not well appreciated by the public that I sometimes wonder how the heck the healthcare system continues to function financially. Right. I mean, because when we look at those numbers on a sometimes yearly basis with the proposals from the government Medicare first, how they want to cut back reimbursement rates, right? And it may not sound like a lot when they say we're going to cut back by 1 or 2%. That may not sound like a lot, but when you scale it across the country and then, or even within a given office or a given hospital or a group of offices, and when you know that there's either inflation or there's escalating, people aren't getting pay cuts. At least I'm not aware. People don't tip. It's not expected or typical. People are getting pay cuts in
Yeah.
the healthcare system, right? When you're employed in these systems. So who's taking the hit? Right. And so it's almost like a constant fight back to stay afloat in the setting of decreasing reimbursements
Yeah.
from insurance plans. Like sometimes it's just like it's a backwards phenomenon. The reimbursements are going down over the years. The numbers are staggering sometimes. We won't get into that right now. And
Yeah.
yet the costs for salaries and for equipment and everything else go up. Like how the heck do we function? Sometimes I don't really figure it
Yeah.
out. So the
Well, I
money thing
think
is real. It's real.
it is real. Yeah, and I feel really good about what we do because I feel like we are the nurses in the clinical documentation integrity department are really trying to find that money that could have potentially been lost to help the
Yeah.
hospitals stay afloat. Because unfortunately, as you know, the third party payers, the insurance companies, they also have nurses on their end and trying to wanting and will deny a diagnosis that a provider clearly documented and treated during the hospitalization. That's part of my job as well to make sure that it met the criteria to allow for billing. That what we say is what we're doing with follow up treatment and monitoring, but the third party payers are coming up with their own
Yeah.
criteria for what
Yeah.
they think meets a diagnosis and they want to deny it. And that delays payment for that particular patient. The payment doesn't get to the hospital. It could be 3-6 months down the road. If the third party payer sets up a denial and then the hospital, someone in my team will then have to decide whether or not we're going to appeal it. And you only have so many appeals before it
Mm.
completely and then it's done.
Oh, really?
Yeah.
Any idea how many appeals we're talking about?
Usually I think 2, 1 or
Ooh,
2,
okay.
and if they don't agree with you, you have to pay that money back to the insurance company because they don't believe that it was, a
Justified.
diagnosis that should be justified. But
So
the
let's put
problem
it.
where is
So if I can frame this for a second, right, and just sit in this for a second. So, because we started off at the beginning, you talked about, the effect of AI, okay, the
Yeah,
effect of information, right? So here we are painting a picture. A patient is, let's use your example. A patient has pneumonia. They have a urine infection to go on top, a little bit of some heart failure, all right? They're not in dialysis, whatever, et cetera. But yeah, it was more than just a straightforward 40-year-old with pneumonia on IV
right,
antibiotics for 2 days and they left. It's a little more
right.
complicated than that, okay? You gave me like some kind of example when we were at Staples, like saying, okay, yeah, if the ER is treating a person for even early sepsis,
Mhm.
right? And when they first presented, they're sick enough that there's some reflection of sepsis, but they
Right,
caught it early enough. They never became full-fledged sepsis. They're not septic. They're not in shock. They didn't have to do a lot of work in the inpatient. I mean, yeah, they had to pay attention to it, but it wasn't like an active, they weren't in the ICU, et cetera. But you find, and so, yeah, if you find that in reviewing the documentation that when the person's discharged, then as you just alluded to, there's not enough documentation here that there was some sepsis at the beginning. That sepsis, it was something that had to at least be attended to. If
right.
that's not in the coding, then that's an impact on the sort of mortality, morbidity scoring and
Mhm,
severity scoring. That
mhm.
can affect reimbursement. That can affect the scoring for the hospital, the practitioners, especially if something goes south, unexpectedly with that patient, et cetera. God forbid, not wanting any bad things for anybody.
Yeah,
But then you're saying that you're now painting a picture whereby we may submit stuff to all these claims to an insurance plan. In the meanwhile, what I experience is, and we've experienced ourselves in our own family as patients, okay, last year with our son being helicoptered down to Boston. We'll talk about that some other time. 'Cause I
oh my
don't think
gosh.
if you don't know about
We have
that.
a lot to catch up
I
on.
don't think you know about that. So we'll talk about that soon. So, and we dealt with this, right? So there's these outstanding bills that haven't been paid by the insurance plan. In the meanwhile, the patients are getting bill after bill after bill recurrently in the mail. And it's just like this trigger alarm, at least for me. And I know for a lot of patients, you
Yeah,
owe
it's stressful.
$3,000, you owe $6,000, you owe $10,000, right?
Mhm.
Because the bill is not resolved.
Right.
And what's happening in the back end is you guys are submitting this stuff, and then the insurance plan is going like, yeah, we don't agree with this, and here's why. And then you got to send an appeal, and it goes back and forth. And the meanwhile, the patients are like, what's happening here? I was
Right.
freaking sick as a dog. Like I almost died. I felt like I almost died. And
Right.
you're sitting here like sticking me with a bill, $10,000, and so on the phone's telling me it's fine, just let it be. And then someone else is telling me like, if you don't pay in the next 30 days, we're going to collections and stuff. And like, what the heck's going on, right?
Yeah, it's
That kind of sucks.
stressful. It does. It's stressful.
And then getting to the point here, you're saying, so our job is to try to do this efficiently, effectively, accurately, integrally. And yet the insurance plans and companies, I'm not even saying they're purposely trying to find, I don't know, they're not purposely trying to deny claims or whatever. But
Right.
yeah, it's like you guys are like, you have your opposite, like bizarro world, upside down world, sort of alter ego, somebody who, are they probably nurses also working for insurance plans? And they're kind of saying, hey, yeah, this isn't correct. We know how you can fix that, but we're not going to tell you. That's how I envision it,
Yeah.
right? We know that that's wrong. We can see the discrepancies, but we're not going to point it out to you because that's on you
Right.
and we can save money. So we're just rejecting that. And then you got to go figuring out why. And so it's a game.
It is.
Is
And
that
that's where
accurate?
we that is accurate. And that's where we come in as the clinical documentation integrity is that we're trying to capture this upfront to prevent that delay. So if we see a diagnosis documented in the medical record, it's not that we might send a provider a query that's saying, there isn't sufficient evidence or documentation in this medical record to support that acute hypoxic respiratory failure diagnosis that's listed there. It's not meaning that it didn't happen, but it might not be in the chart. All of the descriptive and objective data just might not be in the chart. Doesn't mean it didn't happen, but what we are asking you to do is provide additional data up front to support that diagnosis, because an insurance company, if they see a low oxygen saturation, is not going to they don't want to pay for acute hypoxic respiratory failure, which could have increased the reimbursement to the hospital by thousands of dollars just because a patient had a low oxygen sat, right? They
Yeah.
want to see respiratory rates greater than 20 and increased work of breathing,
So you're saying,
documentation to help support it.
You're saying just a low oxygen level it's not enough to justify that diagnosis and reimbursement, but if you support enough other information, then now there's a sort of a more contextual and justified case for it.
Exactly.
Okay.
Yeah. And insurance companies are using AI and they're using other nurses. So hospitals need what I am doing on the back end because it's not going away on the other end, right? But like I said, it's more about the integrity of the chart. Did
Yeah.
this person really have respiratory failure? Or, do they live chronically low? Were they sleeping and they had sleep apnea and we captured that low oxygen saturation and those vital signs? And,
Yeah.
there isn't enough descriptive information to back up the failure. We're just looking to make sure that if it was there, if it happened, that it's in the record.
Yeah. So let me ask you this. What is your observation about why that kind of documentation wasn't there to begin with? That you have to then go back and ask folks, hey, can you beef up your note, basically?
Yeah, providers are so busy. Honestly, I mean,
That's what I'm
especially
assuming.
in the smaller community hospitals, it's just them and the nurses. There's not residents, helping out with their caseload, and they're talking to the families, they're assessing the patients, they're following up on lab results and imaging results. They're getting calls from nurses, they're changing medications, and they have to document all of this. And they have to document it in a way that can be captured by coding, which is a totally different language than what physicians are learning in medical, even nurses. With the language and some of the terminology I never used in 27 years as a nurse. And it's kind of a new vocabulary that I've had to learn for some
Really?
of the documentation. Yeah. We didn't use the term encephalopathic or encephalopathy, metabolic, stuff like that as nurses. We said they were confused or they had altered mental status, but those are symptom codes. Those aren't
Yeah. So
diagnosed.
you're saying certain words they might mean the same thing, but it's like a catch or trigger word that justifies the diagnostic coding and therefore all
Exactly.
the other downstream ramifications of such.
Yeah. And I just feel like, yeah, so I'm very sympathetic to providers' time because there's a lot of demands, they didn't go into medicine to document appropriately. They went in to save lives and make a difference. And unfortunately, just with healthcare the way it is, it really has to be captured. Otherwise, all the
Mhm.
work that they're doing is not getting reimbursed. But I think some of the lack of information in the charts is just they have so much to document and
Yeah.
they're multitasking, but some of it comes from nursing as well. Sometimes I'll have a low oxygen saturation, but I won't have a respiratory rate to correspond with it.
Hmm.
So how can you justify respiratory failure if we don't know what the patient's respiratory rate was at the time the oxygen saturation was low? So some of it is, it's teamwork. It's everybody.
Do
But
you
a
have a
lot of
sense of?
education.
Sorry, go ahead.
Oh, I say another part of what we do as our team is we educate providers and we educate nurses too, is to say like, this is what this is and this is what, kind of criteria that needs to be justified or, can you put the patient's weight in the medical record because the nutritionist diagnosed them with severe malnutrition, but we need
Yeah.
a weight in there to support that they had weight loss from their previous admission. So
Yeah.
yeah.
Do you have a sense of, going back to your comments about just the providers, and we're not just talking about I know you said doctors, but a lot of hospitals have nurse practitioners and physician
Yes.
assistants also as part of that same team. So don't mean to slight them or discredit,
No, no,
invalidate
no.
that or devalue their roles, certainly, but the providers as a whole, okay?
Providers.
Do you have any insights as to observations from your personal experiences as to are providers busier? Do they seem busier now than 10 years ago? If so, any thoughts on why? It just, it's kind of the same. There's other reasons why they're busy.
No. I think they're busier because patients are sicker and patients are living longer. I feel like years ago, my patients that I would, they were sick and you saw a lot in their 70s, maybe early 80s. And now you're seeing so many of your patients are coming in and they're well into their late 80s, early 90s. The longer you live, the more comorbidities, the morbid
Mm,
conditions you're gonna have, the greater increased risk you're gonna have of heart failure, arrhythmias, renal failure, the longer you live. So, but I think some of the initiatives too that have developed over improved documentation do require a little bit more effort on the provider's part because they're also trying to be proactive about some of these conditions when the patients are in the hospital. They're not just assessing the pneumonia and the heart failure. They're looking at everything, all your meds that you're on, all of your other, things, depression, anxiety, your housing situation,
yeah.
your social network. They have to address all of that. And a lot of
Yeah.
that came into the forefront because of quality measures, how to prevent a patient from being readmitted to the hospital again, you
Yeah.
know? So they're addressing everything. Whereas before, I feel like years ago, it was you addressed what was the critical, what was in front of you, why they got admitted. But
Yeah.
it's not as simple anymore. There's a lot of family
Yeah.
dynamic.
Yeah. I hear you. I'll share with you. I don't know if it's the same hospital, but I know somebody who just retired in the last less than a year from
Mhm.
high risk OB
Oh,
work in a Boston hospital. And they were like, okay, no one's keeping, I don't know, they're not keeping personal track and data here, but they said just subjectively, it's clear as day that these pregnant women, they're not in their 80s and 90s, like you say, or late 70s. They're pregnant women. The number and severity of those sick pregnant women who are high risk because of those
mhm.
comorbidities
Uh-huh.
is just overwhelming. Like
Mhm.
the doctors are like, there's a meaningful turnover, constantly looking for doctors because people are leaving, and the nursing staff. It's just it's chaos, right? They said it's just chaos because they're so sick, and it's like taking care of ICU patients constantly instead of level down. They're not normal risk pregnant patients. There's one level up, but now they're all like two levels up.
Yeah.
Right? So
Right.
it feels to me like I don't know what that's about. I mean, there's a lot of we could banter and contemplate on the various underlying issues there, but I also agree with you that the whole metrics thing is just a whole nother animal, right?
Right.
I don't know if you're familiar. I've told a lot of patients over the years that by some observations and some metrics, EMRs, those electronic record systems that had an origin of purpose and intention and with good intention, they have been ranked as like the EMRs has been ranked as the number one cause of physician burnout,
Mm.
more than 1 year in the last 5, 7 years, 6 years. I don't know all the data, but I know it's been at least 2 years that it's attributed as the number one cause of burnout. And it's
Right.
like you say, like, okay, I mean, I joke with patients when they ask me, how come like I go to the office and I'm there for a cough and then they want to collect my urine for some other purpose I'm not even there for? How come I go
Right.
to the hospital and I'm like delivering a baby and I'm like in the middle of pushing and I'm being asked like, do you have guns at home? And do you have, I mean, literally, right? Like in the middle of or in between pushing, it's like, okay, all these other things that have nothing to do with the fact that I am having labor here. Like, are you even paying
Yeah.
attention to the fact that I'm in labor?
Mhm.
It's like it almost feels like, what are we doing here? Like, are you paying attention to me at all? And that's very disconcerting to patients.
It
But
is,
it's
and it
not the
goes
nurse's
back to
fault
the
either.
fact that we're trying to take care of everything when that patient is there. Same thing when they were, before they were going into surgery, I was asking them, "Do you feel safe in your relationships?" I felt so awkward. But that is just I believe that there somewhere down the line, there was a quality initiative that was happened that said if you can intervene at a certain point and you can find it when they're in the hospital, it's easier to reach that patient in the hospital than it is in the community. So we're going to ask these questions. So believe a lot of things had good intent, but
Yeah.
it is putting more burden on the physicians because, like I said, they're going head to toe, psychosocial, and having to try to capture all of that
Yeah.
at an
And I
office visit or in the hospital. And it's time consuming.
agree. And I'm pointing out, it's not even just the physicians or nurse practitioners or PAs. I know the nurses deal with that all the time, right? And they're the ones often responsible for a lot of that intake stuff. I saw it even sometimes, even way back then when I was delivering babies, and I hear patients tell me about it now, right?
Yep.
Because as you said, like it's like there's pressure from outside sources. If you don't get that info, then it has impact on whatever rating scores, maybe reimbursements, metrics that have all this. We don't have enough data collecting and yada yada yada. It's all
Mhm.
insurance expectations, and I'm not even saying as a negative. It's just like you say. I'm with you. I think a lot of the stuff I'm strongly believing that it comes from a good place, but it's just out of hand and out of control, and we can't do it all.
No, I know. I am hoping that between clinical documentation, online medical record, AI, that at some point this will all get cleaned up and a little bit more simplified.
I love
I'm
your optimism.
hopeful. I'm hopeful because I do think an accurate medical record and, patients that are in tune with their diagnoses will eventually yield a positive outcome as far as health, mortalities and longevity for patients. But right now, there's just such an influx of information overload and limited time for providers to be able to catch up to it all. It's moving
Yeah.
so fast.
Do you hear, so this question then, one last question beyond that. Do you hear practitioners telling you, or do you hear scuttlebutt or water cooler talk about patients in the hospitals asking providers or the nursing staff or whoever about X, Y, and Z about their care based on stuff they've read online,
Oh,
like in the hospital or their family members when, overnight before they came back the next morning, stuff like that?
oh yeah. I feel like that, I feel like in the last 10 or 12 years or so, it's gotten more prevalent with access and, to the internet. And now I feel it's probably getting worse maybe with AI because you don't have to search as long, right? When you went to Google or Yahoo, you could hours trying to find the right article about something that you're inquiring in about yourself, but now you ask AI and it pops right up. So I do see a lot of patients and family members coming in and questioning certain diagnoses or why we're doing something or why something wasn't done. And that, while I believe it's good and I feel like there should be an open line of communication, I feel like you should be empowered in advocate for yourself and for your family. It also takes the provider away from the patient itself, the one that they're caring for, and their other patients,
Mm,
because they have to address all of those questions and concerns. And some of them, not to downplay it, they might not be the focus of care at that moment.
yeah.
Like you
So
said, like
I'm,
the chronic kidney disease,
yeah.
it's
So
there, but we're more
I'm
focused
totally with
on.
you. I find that that's one of the biggest things I say. Like, I'm all for people digging stuff on the internet, but the internet doesn't help people, or AI at this point, okay, doesn't help people triage and prioritize what's important or what's not. And also, secondly, like what's more likely or not given your entire story, right?
Exactly.
I have a headache, and like, the people who, no judgment, but people who are more anxious and worried, like, I just keep reading about cancer. I keep reading about cancer, right? You're like, okay, well, the AI, internet doesn't tell you. Yeah, you might find 5 websites that all say if you have a headache, you could have cancer, but it doesn't tell you, well, who's more likely that you have cancer or who's not, right? So the person who's anxious is going to pick up on that and say, I might have cancer. The person who's kind of more minimalist might be like, okay, well, obviously I don't have cancer, so, right?
Yeah, it's
But
true, and nurses are culprits of that ourselves. We've always been known to self-diagnose and, like you said, we see a spot on us and we're like, "Oh, I'm dying." You know, "I'm gonna
so,
die."
real question here, like we have patients all the time. I know everyone relates with this on some level. I had a symptom and I started doing digging online or on AI or whatever, or more so nowadays. I threw my labs into Chat GPT to get like back a report and blah, and this is what I read, etc. My question is because I don't hear yet right now. I'm not hearing patients tell me that live time while they're in the hospital or they're in the hospital like helping take care of their mom who's in the hospital or something like that, that they're actually like getting live time feed about their lab results from the hospitalization and then going home at night or in the hospital as a patient, feeding their info into ChatGPT live time and then saying, hey, I just want to double check you because AI
Yeah.
says this. Is that happening?
I don't think so, not yet
Okay.
at
All
least.
right.
No, and I think partly because a lot of the patients in the hospital tend to be a little bit older population, and so they haven't quite caught up to that yet, and I do feel the older population, the aging population, they still really trust their providers. There's still it's very and I don't wanna say it's old-fashioned, but they trust that their provider is doing what they need to do, and they don't necessarily feel like they have to ask those questions. I do
Mm,
feel like this younger generation that's had more access to online information is maybe questioning, and maybe COVID had a part in it too,
yeah.
but there's a little bit of lack of trust. And all I can say is that I think if anything with all of this is to just really develop a good relationship with your provider, your primary care doctor, so that you have that trust because that's your job to take care of the patient. And while you want to be an advocate for yourself, you do have to have a level of trust in your provider that they went to school for this. They're constantly keeping up on the education, the research, and, that they're there for those questions, and they would certainly let you know if there was something that they was concerned about.
Yeah.
But again, going back to the medical record, though, if you see something in your medical record that you don't think is accurate, I do think that it warrants a discussion with the provider to say, because an online medical record from one visit translates into the next. It
Yeah.
carries over.
Yeah.
There's a lot of copying and pasting. And you don't want
Yeah.
a diagnosis on your medical record if it's not an act because it's going to keep getting copied and pasted,
Yeah. Yeah, we hate to be, I hate to acknowledge that because but it's the reality,
Yeah. And
right?
it's based on time constraints too, you know? Just for an example, I was reading a chart the other day and they said that the patient had chronic respiratory failure. Well, chronic respiratory failure, usually you have to be on home oxygen in order to have that diagnosis. And during the patient's stay, I didn't see any oxygen being used during their stay. And so I was like, I don't think we should be capturing chronic respiratory failure. So I had to go
Mm,
back and dig to when this first diagnosis came up. And it was back around COVID time where they had post
mm,
COVID syndrome and were on oxygen for maybe 6 months or so, but they haven't been on it for a while. Well, I had to send a query to a provider to say, this was a documented medical record. Is this still an active diagnosis? Because I don't see the support for it.
yeah.
So,
That's a great, counterbalance because that's an example of, hey, this is a, overdiagnosis,
right.
not just underdiagnosis and billing in this to the skeptic, okay, more money, but this is an overdiagnosis and we need to take this person off the person's chart.
Exactly. Yep. That's
Yeah,
another thing that we do because, like I said, we want the integrity. We want it to be accurate. We don't want to be charging for, someone or increase someone's risk of mortality or severity of illness because we documented chronic respiratory failure when it hasn't been a diagnosis for 3 years.
yeah. So one last question, and this is so it's been for me. It's been fun. It's been good. It's educational. Even though we sketched out some of this, we try to keep these kind of more
I
raw and
know.
whatnot. But this has been good. So last question. So do you have any? from your perspective as a bedside provider for over 20 years, and then now for the last 3 years on the back end and seeing things from a totally different angle with the consideration of all the changes that have happened in healthcare and better recognizing the different pressures and forces at play that influence the provider behaviors and documentations, the patient experiences and behaviors, et cetera, the nurses and everyone else involved in between. Do you have any like top 2 or 3 recommendations that you would want the lay public, the patients, to any patients know about, whether for themselves or for their parents or in-laws, such that if someone's hospitalized, how might we best optimize our or our loved ones' outcomes and their care experiences in context of all this stuff?
Yeah. Wow.
Big
That's
question, but I
well,
don't
that's
have
a
any
great
answers.
last question. I think it's very important for, like I said, to trust the providers, to always feel like the providers want what's best for your family member and for you, to engage in active communication with the provider or even the nurse who's at the bedside that can have those lines of communication open. Make lists of your questions and prioritize them. Like I said, patients are sicker and there's a lot going on, and we might not be able to address every single problem, but providers, like I said, they want the best outcome. They really do care. And sometimes I feel like because providers are so busy,
Yeah.
um, that gets lost in translation.
I love your comment
Real
because,
quick example. I had a friend of mine who had a heart attack recently,
wow,
and he's okay.
our age?
No, about 10 years older. But, so he got excellent care at a smaller community hospital. They got him in, they put the stents in, he did great. Super happy with his care. But then when it came time for discharge, he called his wife to come pick him up, and they were there for quite a long time waiting to be discharged. And she was texting me, and she was obviously upset. She had other things she wanted to do, and she thought she was gonna be able to take him home at that time. And I had to respectfully say to her, "He's not the top priority right now." And she was
Hmm.
like, "What? What do you mean?" I said, "They got him better. They did what they needed to do. They were there. They did everything. He was priority A number one when he came through those doors, and he had a great outcome. But now their attention is probably on the next sick patient that just came through the door. And
Hmm.
while you are still their patient and they want you to go home and get better, they have to prioritize their day." So, and she's like, "Oh, I didn't think about it like that." And I was like, "Yes, just be happy that he's alive and he's doing well, and you will go home today. But you have to be respectful of all the other pieces and parts that are playing, that are going
Wow.
around." And so I think with AI and with all the technology, it's one thing that I think um, the public, general public, is maybe not as attuned to, is
Yeah.
that providers are also prioritizing their care, right? There might only be one of them or two of them for a wealth or a whole floor of patients, and they have to take care of the sickest first. So when it comes to your questions and and wanting to be educated, timing is everything. Right.
Yeah.
And it
Love that.
might have to be an outpatient follow up where we can go through and discuss everything. But I think just knowing that the providers want the best for their patients is and trust that we are
No,
all doing it for the greater good.
I love that. Number one, and first of all, that's not an easy thing to say to a friend. The messaging there, even if believe it, I think a lot of people, it's not fun to say that. So hey, that's another reflection of the kind of human you are. So, because it's not being mean, it's just shedding light and trying to help reframe things a little bit. And I think that's what it is. So tagging on your comments, I was going to say number one, when you say trust your provider, or the providers involved, like in hospital setting, it's kind of harder, right? Because you don't know them, you've never met them. It's not like you have time to establish a relationship, and you're in this kind of high crisis mode when you're sick, much less especially if you're in the ICU or really sick.
Right.
So I was going to modify, hey, for folks who might kind of go like, well, they're not trustworthy. Like they're not listening to me. They're literally documenting the wrong thing or blah, blah. Cause I've heard those stories too. Perhaps we could at least say, find someone in your hospital care team who you have the most trust with and build a relationship there and use that person as your point of contact at the least.
Yeah,
And then I
exactly.
love the other piece you said was number two, like, yeah, I'm with you. Like people don't go, I don't, I don't think people don't go into medicine, like, especially nowadays, without having some altruistic bone in the body. right? I think people people started somewhere with real genuine compassion and care for people. There's a reason, because otherwise everyone knows it's so hard. You can't go into it, like half-assing it.
Right.
So, but unfortunately, the way I see it is the system is just it breaks us down. We get jaded, we get burned out, et cetera, et cetera. And so, what a lot of people experience is unfortunately the rough side of you know the practitioners or the care team or whatever. But it's not personal, and
Mhm.
it's not that they care about you less per se. It's kind of unfortunately the way it might present or come off. So I love how you said that too. Like, just know it's not intentional.
Right.
Even if it's not the best, but people they're still caring about your best outcome, right? And then thirdly, I think last again adding to your comment, hey, there's a lot of information out there. That's something we kind of touched on a lot in different pieces today. It's something we talked on all the time on the podcast. It's information overload in a lot of ways. I love what you said. Prioritize your topics, and maybe that prioritization is based on what the person thinks is most important to them, i.e. like this is an emotional thing for me.
Uh-huh.
Or it might be, hey, if you're using AI and you're trying to figure out what's most important, then hey, use that, whatever it is. Or even ask somebody, ask that care person that you feel you got the most trust with, what is these are three things I have concerns with, like which one of these three should I be most concerned about?
Right.
Or I have questions about all three of these, which one do you think is the most important that I want to just grab your attention about for 2 minutes, whatever.
Exactly.
I love that. I appreciate that.
I think with access to everything now and just our generation in general, we want answers quickly, fast. And unfortunately in healthcare, it might be you might have to have some patience in that because there's so many other moving parts going on around,
Yeah, yeah,
um, hospital at that time. And you will get your answers and you will be able to address them. It's just there are a lot of other factors coming into consideration and other people's lives that are being,
yeah,
challenged at the same time and, you know,
yeah,
prioritize. Yeah.
yeah. No, it's been good. Yeah, it's been good. I appreciate you as
Yeah.
a. We haven't touched base in a long time. I know we're gonna get together with the spouses
I know
soon,
I'm
but
excited to catch
yeah,
up.
yeah,
We sounds like you have some stories for
we have some
us.
fun things to talk about. Yeah. No,
Yeah.
but again, I appreciate you as a, I've always seen you as just a real down to earth and relatable and an integral person of character. And just, so I appreciate the way you not only just articulately explain a lot of the stuff about your role and what happens on the back end from your observations, but also just your different angles and sort of balanced, reasonable perspectives on life in this increasingly challenging healthcare landscape.
It's a lot to navigate. And like I said, I recently had a family member that was in the hospital. And, I step in there and I feel like a fish out of water, even
Mm,
though I've spent most of my life in the hospital. But
wow.
when it comes to being a family member, I didn't want to step on people's toes. I was trying to be respectful, but I had questions. So I've tried to navigate this myself from the other side. And I get it's stressful, it's emotional, it's overwhelming. But just reach out to your colleagues and your peers and, like you said, find that one person that you can trust because everyone's trying to do a good job. Everyone wants the best for their patients. And full circle real quick when it comes down to the documentation that I was telling you about, all the other reason to capture all those severity of illness and risks of mortality, right? Because those help to secure our resources in the hospital, the number of nurses that are on per shift, the number of providers, and all of that comes into play because the patients are sicker. The families have more questions because the patients are sicker and there's so much going on. And so I think it's just full circle. There's a lot going on, but I think eventually everyone will be on board and realize there's a benefit to everything. We're in a very difficult time with technology right now and cost of healthcare.
Yeah. Yeah, I think so too. I mean, anytime something's new, um, there's a waves that are they're big waves, and until
Mhm.
things settle down, then and fall into a groove, then we're sort of just having to bear it until that time comes. So thanks very much, Amy.
Yeah, thank you. I look
Yeah, that was
forward to
fun.
talking to you.
Yeah, and we'll look forward to seeing you on the social side of life, in the near
I
future
know.
here.
It's been
And
long overdue.
yeah,
I
it's been a
appreciate
long
you
time.
reaching out to me. I wasn't sure I was gonna have much to offer you, but
I I told you, I was like, I'm gonna ask you if I didn't think so. So I appreciate you. Like I said, very articulate and a lot of insight. And, so yeah, as always, we're trying to provide service and hold space for patients, both in the conventional and functional, but especially in that functional medicine world. The conversation here with you today is much more on the conventional medicine side, but it all comes together, right? Because we can't exclusively operate in the functional medicine world. So I appreciate your time. And for anyone else, of course, as always, if you want to get a hold of us, first time consultation, second opinion consultation, et cetera, or just to get a sense of who we are, how we may be of help or benefit to you, your family members, et cetera, rootseekhealth.com is how you can reach us. And our team would be happy to be available. We'd be honored and privileged to walk alongside you in your journey, wherever that may be. And Amy, thanks again for your service to your hospitals, the teams that you work with in the hospital, and to the greater humanity at large. So
Yeah, I
thanks much.
appreciate that. Thank you. Thank you for having me.
Yeah, absolutely.
Bye.
So fresh, just the way you like it.